right ahead.
Okay. And you're going to be recording?
Yes, we are recording now.
Very good. This is Dr. Carolyn Jones-Assini, Chair of Ellis Internal Medicine. Welcome to the fourth Ellis COVID-19 Grand Rounds webinar. I need to tell you a few things about our CME and our MOC points. You can claim both CME and ABIM MOC points, and to obtain them, you must send in the evaluation survey. For the MOC request, we need you to complete an MOC form, and the links will be given in this program, or contact Amy Semerod, and she'll send the link to you. Our next COVID-19 Grand Rounds will be held next Friday, where Dr. Peter Weinberg will lead us through a broader look at the various clinical and therapeutic aspects of COVID-19. Our Grand Rounds today will examine 3 drugs being used to treat COVID-19. I want to let you know that none of our speakers or planners have any conflicts of interest to declare. Now, that being said, never have we had, as a community, been more acutely interested in our topic today, searching for a treatment to save either a family member or a friend or a neighbor. And our family personally has a friend at this time on a vent at Albany Medical Center. So again, great import and interest to what we are discussing today. So 2 particular drugs classifications will be tackled today, and we have 2 speakers that we so greatly appreciate their time and effort in putting this so quickly together for us. Our first speaker is Dr. Peter Weinberg, a pulmonary critical care specialist serving in our Schenectady community since 1983, who even in retirement has maintained his great interest in teaching, and he works with both our family practice residents on a regular basis, as well as our wonderful team of registered dietitians. Our second speaker will be Dr. Robert Dachs, and he is Vice Chair of the Department of Emergency Medicine at Ellis, and he also is very involved in medical education on our committee and as Associate Clinical Professor of the Ellis Family Medicine Residency. So, following their presentations, we plan to have an update on a Remdesivir trial here at Ellis, which is being led by our Division Chief of Infectious Disease, Dr. Douglas Finch. So again, first, we will start with Dr. Peter Weinberg.
Thank you. Let's see. Okay, am I on? Can you hear me?
Yes, you're all set. You're ready to go.
Okay, can you hear me? Hello?
Yes, I can hear you.
Okay, good. Thank you. Welcome, everybody, in our series of Grand Round presentations on COVID-19. And the title of today's talk is Opinivir, Ritonavir, Remdesivir, Hydroxychloroquine, Hype, Help or Harm. The title of this Grand Rounds is courtesy of Dr. Robert Dachs, and with apologies to him as I left out the question mark. My topic will be the discussion of 2 medications that have recently come to the fore in the online literature circuit. And they were suggested to me indirectly by Carolyn Jones-Assini, who suggested that we have a journal club presentation on certain aspects of COVID-19. And I selected 2 articles and will be presented them in a journal club fashion. Before I start, I do want to express my thanks to all those who are on the front lines, both in the medical and non-medical communities. I have 2 significant disclosures. Obviously, I'm a proud grandparent and have, as was indicated earlier, no conflict of interest. The objectives today will be to review the basis for and discuss the clinical utility of two COVID-19 medications as presented on,
Back to the right.
I'm sorry? In two publications online on the New England Journal of Medicine website. The first one we'll discuss is the combination loperamir, ritonavir, also known as Coletra for those who take care of HIV patients. Loperamir is an antiretroviral protease inhibitor that is used in combination with ritonavir, which is also a protease inhibitor, but also inhibits cytochrome P450 3A4 to increase loperamir levels. Now, most of you have been indirectly familiar with cytochrome 3A4 inhibition from the labels that you see on medications which advise people not to take grapefruit juice, which is a potent CYP 3A4 inhibitor, which as it will raise drug levels in certain medications. Now, the combination of loperamir and ritonavir, which I'll refer to as LR, is used to treat HIV, Hep C, HPV, SARS, 1, and MERS. And the interest in loperamir ritonavir for treatment of SARS-CoV-2 stems from prior studies using an LR in the treatment of MERS and SARS-1, both in human and animal models. And as you can see here, this is from one slide taken from thorax in 2004. It was effective in decreasing viral load as well as causing clinical improvement. But of interest is the majority of these studies involved combination therapy with ribavirin, which has been found to increase loperamir levels fourfold. And this may have some clinical input. So with that as a background, a trial of LR in adults hospitalized with severe COVID-19 was published on March 18th of this year in the New England Journal of Medicine. The study was an open-label, randomized controlled trial performed between January 18th and February 3rd of this year. LR was given as a fixed-dose tablet, 400/100 milligrams twice daily, plus standard care for 2 weeks. This was compared to standard care alone. Entry criteria in the study, as you can see here, are 1, confirmed SARS-CoV-2 by RT-PCR, pneumonia on chest imaging, which is chest X-ray or CT scans, and hypoxemia as documented by a pulse oximetry reading of less than or equal to 94% on room air, or a PF ratio of less than 300 millimeters of mercury. Now, for those who aren't familiar with PF ratio, that's just a way to try to standardize one's degree of hypoxemia to the amount of oxygen you're breathing. And just to give you an idea of what that is, if we take a normal blood gas on room air, the normal PO2, the partial pressure of oxygen, is about 97 millimeters of mercury. If you divide that by 0.21, concentration of oxygen in room air, you'll get a PF ratio of 461. There's a slight variation, and if you breathe 100% oxygen, your PF ratio should be, with normal lungs, greater than or equal to 550. Now, as we classify lung injury, a PF ratio of less than 300 millimeters of mercury is the cutoff point for mild ARDS. As you go down, a PF ratio of less than or equal to 200 millimeters of mercury indicates moderate ARDS, and that will correspond to a PO2 of 42 on room air. And severe ARDS, to put things in perspective, which is a PF ratio of less than 100, would correlate with a PO2 of 21 on room air, much lower than venous oxygen. And if you were looking for, if you look following SAT of 94%, corresponds in general to a PO2 of about 73. So that being said, the primary endpoint of the study was time to clinical improvement of greater than or equal to 2 points on an ordinal scale listed below. And starting from the most severe Grade 7, which is death. We progressed with improvement to being hospitalized on invasive mechanical ventilation and ECMO, hospitalized on either high flow nasal cannula or non-invasive ventilation, and hospitalized on supplemental oxygen, hospitalized not on oxygen therapy, and then discharged from the hospital unable to resume normal activities, or discharged and able to resume a normal life. 357 patients were assessed, 199 underwent randomization. 99 were assigned to the LR group and an intention to treat model, and 100 were assigned to standard care. Of those in the LR group, 3 died prior to receiving LR, and so 96 were included in the modified intention to treat trial. 2 did not receive LR. 1 patient in the control group did receive LR, and that patient was included in the safety evaluation. Although it's a cumbersome slide, if you can scroll down, you see that the study was actually pretty careful about documenting a patient's degree of illness, and they were able to randomize their patients and follow them in batches so they could more evenly distribute the patients. If you look further at patient status and treatments received on our after enrollment, you have the following table. And of particular interest, if you go to the bottom, is you look at the treatments during the study period. And if you follow down, and unfortunately I don't have a pointer, you could see that during treatment, more patients in the standard care group, 27 versus 17, required vasopressor therapy. There was a slight increase in renal replacement therapy and non-invasive mechanical ventilation, as well as invasive mechanical ventilation. However, this did not translate into significant clinical improvement. You can see from this figure that while there appears to be a slight clinical improvement in the LR group compared to control, this was unfortunately not statistically significant. Likewise, the decrease in viral load was not improved with the use of LR, an antiviral agent. If you look at outcomes in the intention to treat population, we'll see that the time to improvement, again, showed no difference, but we'll look at the clinical improvement percentage. The 28-day mortality did not show a statistically significant difference, although if you look, mortality was lower in the LR group with 19 deaths, and if you remove the 3 prior to receiving LR, then you can say that only 16 patients died while on LR, as opposed to 25 patients who received standard care. If you go down to length of stay, you'll notice that of the survivors, there was a 2-day difference in length of stay favoring LR. And this brings to mind a debate that we have all the time at what should be appropriate endpoints. And if one looks at an intervention that may not be particularly expensive, then although mortality benefit may not be seen, care may have a significant impact on the choice of whether or not to use a particular intervention. Looking at adverse effects, although I didn't chart it here, there was no significant difference in adverse effects that were non-life-threatening between the 2 groups. However, in looking at serious, life-threatening adverse events, you'll note that there was a significant difference favoring LR intervention. The total was 17 adverse events, grade 3 or 4 in the LR group versus 31. And in particular, respiratory failure or ARDS was much more prevalent in the standard care group, as were certain other aspects seen below. So, overall, LR is not effective. However, no ribavirin was used in the study, which may have adversely affected the LR efficacy. The average time to initiate LR was 13 days. You can see the range of 11 to 17 days. And this is really too long for the clinical effects of an antiviral agent to be manifest, because you really want to decrease the viral load before it has a significant impact on the body's defensive and immune systems. And although not statistically significant, mortality in the modified intent-to-treat model, modified intent-to-treat model, was 16 in the LR group versus 25 in the standard care group. And once again, the ICU length of stay in survivors was 2 days shorter in the LR group. And this brings us to my usual mantra for evaluating any therapeutic intervention, in particular pharmacologic, which always uses the right drug. Perhaps in this case, we should have added ribavirin, the right dose at the right time, and perhaps early intervention would have been better, and in the right patient. And again, patient stratification may help in this case. This brings us to our next medication, remdesivir. Remdesivir is a rather potent antiviral nucleotide. It's an adenosine analog that inhibits multiple DNA-dependent RNA polymerases and consequently has activity against many RNA viruses. These include Ebola, Marburg, SARS-1, MERS, and SARS-CoV-2. Now, this led to a publication by Gilead summarizing its results of compassionate use of remdesivir patients who have severe COVID-19 disease. And if you'll note here, you'll note that we have 55 contributors. And this was an international study with patients recruited from the United States, Japan, Europe, and Canada. The entry criteria were similar to those of the LR study. You have to have a SARS-CoV-2 infection documented, or rather confirmed by RT-PCR. Pulse oximetry reading of less than 80 to 94% on room air, or the use of supplemental oxygen. You have to have a creatinine clearance of greater than 30 mils per minute. And liver functions, as represented by AST ALT, should be less than 5 times the upper limit of normals, and no other investigational agent should be used. Patients were given remdesivir 200 milligrams intravenously on day 1, and then 100 milligrams IV daily for the subsequent 9 days. Patients were followed for 28 days, and patients were divided into 2 groups, including invasive ventilation, which referred to patients receiving mechanical ventilation or ECMO, and non-invasive oxygen support, which included non-invasive positive pressure ventilation, high flow nasal cannula, low flow nasal cannula, and ambient air. Improvement criteria were similar to those used in the LR study. They used a similar assessment scale with only 6 categories, the worst, of course, being death, and then followed with improvement, hospitalization requiring invasive mechanical ventilation, hospitalization requiring high flow nasal oxygen therapy, non-invasive ventilation or both, hospitalization with supplemental oxygen, and then discharge without supplemental oxygen, and discharged. Excuse me, I take it back. This should be requiring supplemental oxygen, and then discharged completely off oxygen. My bad. The demographics are listed here. Unfortunately, there's obviously no control group. But as we can see here, for comorbidities, they were obviously more prevalent in the more seriously ill patients. And so what are the results? 61 patients were enrolled, 8 were excluded, and 53 were analyzed. Of these 53, 34 from invasive ventilation, as we mentioned earlier, and 19 received non-invasive support. Now, of the 34 invasive ventilated patients, 6 died, 16 improved, 8 were discharged, and these were using the study's criteria of improvement in 2 or more categories. The authors, unfortunately, violated their own criteria to have 19 improved by using criteria of only 1 category, which violated their study premise. Of the 19 non-invasive supported patients, 1 died, 1 failed to improve, and the remainder 17 improved, all whom were discharged. Mortality was associated with advanced age and elevated baseline creatinine. And obviously, the sicker the patients were, the higher the mortality. The overall mortality in the series was 13%. 18% on those patients who required invasive mechanical ventilation, and 5% in those who involved non-invasive support. More adverse events were noted in the invasively ventilated patients. Obviously, the sicker you are, the more likely these are to occur. And 12 patients, 23%, were on nasal cannula or room air at baseline. And contrary to the abstract, as I mentioned, improvement seen in 33 versus 36 of the patients, or 62%. And this is a graphic representation from the study of their results. And if you look at the 34 patients who were placed in category 5, invasive ventilation, of those, 6 died, 9 remained on invasive ventilation at the end of the study, 3 improved only by 1 ordinal point, and 16 others had significant clinical improvement. In the non-invasive group, 7 patients, 1 died, 1 remained on treatment, and 5 were subsequently discharged. And of the 12 patients on low-flow oxygen and ambient air, room air, all 12 were discharged home. So there are lots of problems with the study. And to begin with, I always like to have my antenna raised, and they tend to be raised when my Weinberg postulate is invoked, which is that there is generally a problem with the study when the number of authors exceeds the number of patients. And as I pointed out before, we had 55 authors and 53 patients. Now, as far as problems with the study, unfortunately, there's a tendency for pro-Gilead bias, and at this point, one can, of course, argue that one can evoke an ad hominem negative approach, which I will reject at this time. The program was designed and conducted by Gilead Sciences. The sponsor collected data, monitored the conduct as appropriate, and performed the statistical analyses. While authors had access to the data, the initial draft of the manuscript was prepared by a writer employed by Gilead and had input from one of the authors and subsequent all other participants. There's a problem with patient selection, and it seems that it's perhaps cherry-picked, because Gilead had given compassionate care Remdesivir to hundreds of COVID-19 patients, and yet selected only 61 for this publication review. Well, 8 patients were lost after day 1, and we had obviously a small study size. There was no control group. There was no randomization, obviously. There was no patient severity stratification, and this has some clinical bearing for those in the field. And unlike the title, not all patients had severe COVID-19. In fact, I'm not sure if you can classify patients who are on ambient air as having severe COVID-19, nor people who are on low-flow oxygen therapy. There was a significant number of mild patients, which is a corollary of the prior statement, in that 12 of the 53, 23%, had either no or low-flow oxygen. All were discharged home, and the question was, did we have a medication effect, or was this just an epiphenomenon, being true and unrelated? There was the clinical baseline data were rudimentary. There were no severity of illness scores recorded, PF ratios, hemodynamics, disease markers that are particular to COVID-19, such as D-dimer, ferritin, fibrinogen levels, LDH, CRP, procalcitonin, and lymphocyte levels, which have prognostic implications, renal hepatic markers, myocardial markers, etc. Endpoints were not specified. There was a delay in the administration of Remdesivir. As mentioned earlier in the LR study, this has clinical implications. Remdesivir was given 12 days after symptom onset. And certainly, if you want to decrease a viral burden, you want to give that early on in the course of the disease. And this is important in particular as later COVID-19 signs and symptoms reflect the body's immunologic response, not just the viral load. Actually, it affects viral load perhaps indirectly due to the damage that the virus can do to the body, as well as the triggered immunologic response. No viral load data were provided, and this would be important to evaluate the effects of the antiviral drug. And as we saw earlier in the LR study, LR had no effect on the decrement of the viral load. It is also unclear whether adverse events reflected the drug or the disease, as we have no control group. And furthermore, and this is particularly going to me, there was a requirement for an adverse event to be listed that it had to have at least 2 patients manifest it. So if one patient developed a severe adverse event, such as anaphylaxis, it would go unnoticed. And in particular, when you have a small study, this is very significant. Reported outcomes violated their own improvement criteria, as we mentioned earlier. However, at the end of the study, the authors very appropriately concluded that the findings from these uncontrolled data will be informed by ongoing randomized placebo-controlled trials of remdesivir therapy for COVID-19. So, in sum, how would it put it together? Well, we can summarize the study, at least I will, in 2 sentences. We took COVID-19 patients, we gave them our drug, and this is what happened. And we need better studies, and we are doing them. And I apologize for the spacing. That is because of using a Mac. Again, this is how I was feeling several days ago. And then, why publish these data? Well, possibly to enhance our clinical knowledge, although there are lots of reviews on the clinical aspects of COVID-19, or maybe there's something else. And I recently came across this post. It's from an investment site, and it's titled, Gilead Sciences Remdesivir Data Release Brings Much Needed Relief for Patients and Investors. It cites the NEJM article, and it comments that in the NEJM article, 36 out of 53 or 68% of COVID-19 patients witnessed an improvement in oxygen support. They then cite the mortality data of only 18%, and they compare it to other published data, which have mortality as high as 80% in people who are on mechanical ventilation. And then it concludes with a statement that while the high fatality rate in these studies may be attributed to constraints in hospital space and resources and different test centers, the sheer discrepancy between mortality rates of patients requiring ventilation who are treated with remdesivir and those who are not points to potential efficacy of the former. While this is true, it's sort of worded in a way to foster investment. Also of note is the fact that when studies are published, the journal that publishes them tends to receive money from the company that sponsors them in the form of purchased reprints in the numbers of thousands. And this is something that has been commented on in the literature and several editorials, both in Lancet and British Medical Journal, as well as online forum comments. Now, is remdesivir a bad drug? No. Is it useful? Most likely it is. And as you heard, there are currently several rigorous clinical studies that address the role of remdesivir in the treatment of COVID-19. And as Carolyn pointed out, we are participating in a study here at Ellis Hospital in the use of remdesivir in COVID-19 under the aegis of Dr. Doug Finch. So where does this leave us? Again, when evaluating therapeutic interventions, especially with pharmacologic agents, always make sure you have the right drug at the right dose, given at the right time for the right patient. And with this, I will also caution everybody not to fall prey to premature factuation. And with that, I'd like to thank you for listening and take the opportunity to introduce Dr. Robert Dachs, who will give us a very thorough and insightful presentation on the utility of hydroxychloroquine in the management of COVID-19. Thank you very much.
Thank you, Peter. You talked about Remdesivir, and we're doing the trial on Remdesivir that Dr. Finch is involved with. I don't know if you'd like to weigh in at this point. It would be a perfect time to comment on your analysis and where we're going with it here. If he feels comfortable chiming in at this point. Are you on, Dr. Finch?
Yeah, can you hear me?
Yep, we can hear you.
Can you hear me?
Okay.
Yep, and I'll set up my slides in the meantime.
So yes, that was an excellent review of the Remdesivir. So what I think we're learning, one of the things that we're learning from this crisis is we're all getting a crash course in clinical research. So what was just presented by Dr. Weinberg was results from compassionate use. And I think it's probably unusual that they would be publishing results from a compassionate use trial, because that's what we really want, are randomized controlled trials, placebo-controlled trials, and Remdesivir that is ongoing for Remdesivir. What we have here is expanded access use trial of Remdesivir. So this drug is not FDA approved, but it's going through that process. So what I want to talk about really is what is an expanded access trial. So these are trials that take an investigational new drug outside of a clinical trial, and they're looking for, basically in this trial, adverse effects. We're not looking at any clinical outcomes. That's sort of secondary. The primary purpose of an expanded access trial is to provide access to a drug that may be of benefit to people that are seriously ill before that drug is FDA approved. So we're obviously in an emergency. The trial is providing treatment for up to 15,000 patients. Initially, it was going to be for 5,000, and this is going to be at multiple sites. We're approved for treatment of 10 patients. So far, we put 5 patients on treatment, and the inclusion involves patients that are seriously ill. Now, I agree with Dr. Weinberg. This drug might have better uses outside of the seriously ill patient, but at this point, there's limited amounts of drugs. 15,000 may sound like a lot, but that's probably more than what they have in stock, because they're starting with 5,000. And I think the decision was made to make the drug available to the sickest patients. And one of the other criteria to have an expanded access trial is that there's no comparable satisfactory alternative therapy. We heard about Kaletra. That's an off-the-shelf drug that was being repurposed for coronavirus. We're going to hear about hydroxychloroquine and chloroquine. Those are off-the-shelf drugs. So I can't really say about the results because I'm in the middle of it. So part of the issue with using new drugs or using a drug during a crisis is that people are prone to confirmatory bias. So we go through this all the time. You give something, the patient gets better, so it must have been what I did. The patient dies, the medication did something. We can't really tell. We need randomized controlled trials to really tell the difference. And I think we are providing a service to Gilead. They're getting additional safety data that's going to help them get on the market. And I agree with Dr. Weinberg that it's to their benefit for us to help them with this drug, because if this is effective, it's going to be a mega blockbuster. They're going to make $1 billion or more. So currently, our drug is limited to people that are on the ventilators that, in short, are not in multi-organ failure. We had to apply and go through our IRB to get approval. Well, first, we had to ask Gilead if they would include us in the expanded access trial, and they did, probably because we're the only hospital here in Schenectady County and upstate New York. And then the IRB had to go through and approve everything. And I can tell you all the communication from the study sponsor, which is Gilead, is all about safety issues. And we're going back and forth about, we're telling them every day what's going on with the patient. We're reporting their labs, we're reporting their clinical status. We have to report any potential adverse event and serious adverse events, which of course would be death. And death is expected in those patients that are on the ventilator. So we know that 8 to 9 out of 10 patients that are on the ventilator right now are on for an extended period of time and may never get off the ventilator. The process to get into the trial was not too difficult. Once we were approved, there were some forms to fill out. The FDA has approved the expanded access, and this is I think our second or third week in the expanded access trial, and already FDA has made Gilead make some safety amendments to the trial, some changes, some inclusion in the inclusion criteria. They expanded the access. Originally, it was for 18 and older non-pregnant patients, and now it's expanded to 12 to 18 and pregnant patients. We're not going to do that here because we don't have the really capability to take care of those patients in general. We are enrolling, and Albany Med is in the process of enrolling in the expanded access trial. That's all I want to say about what I'm doing.
Great. Thank you. I think we're doing a real service trying to get into this trial, being in this trial, because what Dr. Weinberg has pointed out is that we're very, very early on in trying to decipher the right drug, the right dose, the right time, the right patient. And as I go through my presentation, you're going to find the same thing. So for those of you who tuned in looking and hoping that Dr. Weinberg or I would show you the silver bullet, I'm going to preempt myself. There's no silver bullet. We're very early on, and we have to find the right patient, right dose, right timing for these drugs. So I'm going to go very quickly through hydroxychloroquine because it's obviously been in the news. I have nothing to disclose. I have my learning objectives. I want to just cover in my 20 minutes some of the pharmacology, some of the background, where we stand with it, and some of the toxicity treatments. So here we go. The pharmacology, these are chloroquine and hydroxychloroquine are known as 4-aminoquinolone compounds. The first one, chloroquine, was developed as an anti-malaria drug in 1934. 10, 12 years later, hydroxychloroquine came along, and the benefit of hydroxychloroquine over chloroquine is it's less toxic. The toxicity associated with chloroquine is significant, in particular retinopathy. And in fact, you cannot get chloroquine here in the United States. It is still used worldwide, but in the United States, we only have hydroxychloroquine. Brand name is Plaquenil. Some of you might be familiar with that. It can be used for malaria, but we'll probably see it more used in rheumatoid arthritis and in lupus patients. That's where it's commonly used in the United States. All right, so as we repurpose these older drugs for potential use in COVID, why did they come up with hydroxychloroquine? Well, there was 4 potential theories on why hydroxychloroquine may work. I'm going to go through them very quickly. So here you can see you have your coronavirus and with spike proteins that adhere to the ACE receptor. It then enters what is known as an endosome. That endosome fuses with a lysosome. It then takes harbor in the lysosome, then breaks out, and then infects the rest of the cell. So what hydroxychloroquine is thought to potentially do is hydroxychloroquine is a weak base, and the milieu of the endosome and lysosome is acidic. So the thought is that as this hydroxychloroquine enters, goes into the endosome and lysosome, it will make this whole environment dysfunctional to the virus. So it will block, the endosome fusing to the lysosome and subsequent living space for the virus. It's also thought that it may block this proton pump here that pumps hydrogen ions in to keep it acidic. That's another potential thought where it may work. The other area where it may work is that apparently chloroquine and hydroxychloroquine is a zinc ionophore. You might be saying, what is that? All right, so for zinc to get inside a cell, it needs a transport mechanism. It just can't make it through a cell membrane. And it appears that chloroquine is this transport mechanism. And by transporting zinc into the cell, zinc has been shown to be useful to inhibit this RNA polymerase. If you can inhibit the RNA polymerase, you can decrease viral RNA replication. That's also the same spot where we're talking about remdesivir and the other antivirals to stop this viral RNA replication. The third area where it's thought that hydroxychloroquine may work is that associated with this ACE receptor is a sialic acid receptor. And this sialic acid receptor acts as a spike protein. It allows the spike proteins to adhere there. So ergo, the thinking is that if hydroxychloroquine can goof up and bind to that sialic acid receptor, you can also inhibit the spike proteins from attaching. So there's a bunch of in vitro studies in the test tube. All the data suggests this should probably work in the test tube. I put up a bunch of them here. There's another one, another study here, the fourth study. So in the test tube, it looks like we got great results. The problem is when you take it from a test tube into in vivo studies. And I'm going to show you what studies are out there. I'm going to call this the wild, wild west of studies at this point. There are 6 studies that you can find online that have looked at hydroxychloroquine, 3 French, 3 Chinese, that have given their results. These are all before print, they're before preprint. 5 of the 6 trials had no peer review. The 6th trial had a very limited peer review. So this is, and you'll see these trials are really limited, small size. Some are positive, some are negative, and they're all looking at different endpoints. So you're going to say this all looks very confusing. You come out at the end of these 6 trials saying, what the heck? So let me just go through them because you may be shown these so you just know what's going on. So I'm going to do the 3 French trials. The first one that came out was this positive trial that everybody was very excited about back on March 20th that said, look, after 6 or 7 days by giving hydroxychloroquine and azithromycin, we can decrease those patients and improve their viral clearance by day 6. As you see, this is not a randomized trial. They just took 20 patients who had it, and then at another hospital, they took 20 patients who didn't get hydroxychloroquine. I'm sorry, 16, not 20. A few more got azithromycin, and what they found was, oh yeah, we had improved viral clearance on day 6 in those who got hydroxychloroquine. Well, as you can see, it's almost laughable that they did not include this 6 patients in their analysis that got hydroxychloroquine, 1 that died, 3 get go to the ICU, 1 gets adverse drug events. And this paper had a very limited peer review. It's actually written by the editor himself of that journal, and he had just had a junior person review it before he published it. The same group and this editor on April 1st said, no, now we're up to 80 patients, and oh yeah, this looks great. Take it for what it's worth. And the endpoint is, again, viral clearance, not clinical outcomes. Apparently, there's a battle within the French medical community because this French author and his colleagues said, well, we looked at 11 people, and we just didn't find any benefit. And, you know, I mean, how you even print something involving 11 people is laughable in of itself also. There is some China trials I'll go over with very quickly. The China trial here, number 1, this looked at some 62 patients. Again, they were open label, non-blinded, and they looked at some sort of clinical outcomes. They said, look, we can decrease fever by 1 day. We can decrease the cough remission. And again, they didn't give any documentation of this. They said, oh, look, the CTs look better in the people who got the hydroxychloroquine. Again, not randomized, not blinded. The second Chinese trial looked at, again, this was a small trial that looked at some 30 patients. They supposedly randomized these 30 patients, 15 got, 15 didn't. And they looked again at throat swabs at 7 days. So this completely contradicts the French trial that looked at throat swabs at 6-7 days. Here they said there was no difference. Now, this paper is only written in Chinese. You can only read the abstract in English. So it's very, very confusing and very, very concerning. There was, I'm sorry, it's not on these associated slides, but there was a more recent trial that came out 2 days ago that Peter sent to me, and I appreciate. That was another French trial, was some 150 patients, 70 that they did randomize. That was 75 who got, 75 who didn't get. Their outcome was viral shedding in 28 days, and their primary outcome was no difference. But then if you go through the paper, they say, look, there were some secondary markers of improvement with hydroxychloroquine, such as we decreased the CRP and we improved the lymphocyte counts. These are surrogate endpoints. They're secondary endpoints. So, it may be somewhat promising, but you can't take anything home to the bank on that. So the question then becomes, why do you get a difference between these in vitro studies and in vivo studies? So in vitro, it looks great. It looks just fantastic. Why do you get something different in vivo? And we actually did see this in what is called the paradoxical effect of chloroquine treatment in chikungunya. So it was very interesting. With chikungunya, if you infect these cells in vitro, the Vero E6 cells, with the virus, and you have a milieu of chloroquine around there, you could inhibit the infection with chloroquine. So in vitro, it looks great. But when they took it out to the field, they first did it in primates, in other words, they took these monkeys. Some got chloroquine, some didn't get chloroquine, and where they found the ones that got chloroquine did worse. They had higher viremic loads, they had slower viral clearance, they had delayed immune responses. And there was actually a trial known as the Cure-a-Chick trial that they actually took humans and double-blind randomized them to getting chloroquine versus non. And those who got the chloroquine actually did worse in the long run regarding their arthralgias, which is the long-term effect of chikungunya. So gratefully, and Dr. Finch alluded to this, and the Infectious Disease Society came out with their position statement just 3 days ago. And what they said was essentially what Dr. Finch said and what we're doing is that when it comes to hydroxychloroquine and chloroquine, you should only consider giving this. We recommend that it be given in the context of a clinical trial. Same thing goes for the hydroxychloroquine plus azithromycin idea. They recommend that it should only be given in the context of a clinical trial. Now, that may seem a bit conservative, and when it comes to the clinical trials, there's a boatload of them. As you can see, I downloaded this back as of March 24th. There's been many, many, many more trials initiated since then. There's something known as the Discovery Trial, which is a 3,000-person trial. New York State's involved in a trial. Rutgers University is involved in a trial. Even in the state of South Dakota is now getting involved in a trial. So when you see these trial publications come along, you're going to have to really be very skeptical and look at them very critically as to, are they peer-reviewed? How are they done? What were the endpoints? Is the endpoint just viral clearance, or is the endpoint a clinical outcome of concern to you and the patient? So that's my take on the literature that's involved thus far with hydroxychloroquine. So we're sort of still in this conundrum. What do we do? Do we just give it? Because, heck, what do you have to lose? And it doesn't kill people because it's been around in the form of Plaquenil. All right, so we do have to recognize the side effects associated with hydroxychloroquine. And interestingly, and this is, in my realm, poison control centers and side effects I see in the emergency department patients who come in with adverse events from their drugs. And fascinating, since mid-March, the number of calls to the poison control centers nationwide has doubled compared to the same time last year. So there's people taking it, people concerned, people potentially getting side effects. So a bit of the pharmacology that you need to know. It's only available orally. There's no IV form, so that if you're giving this to patients who are intubated up on the floors or in the unit, they can crush this and put it through the feeding tubes, but it is only an oral formulation. It has very good oral bioavailability. You give it, it gets into the gut, and you absorb it. And it goes everywhere. It goes to your kidneys, liver, muscles, brain, eyes. It penetrates widely. It goes everywhere. It's metabolized in the liver and excreted in the urine. And as you see up there, the half-life is really, really long, 22 days. So you have to understand, even after you've given this drug, you'll continue to get slow release of the drug into the plasma for years. So, just imagine, you give a drug day one, you get some levels in the plasma. Day two, you're going to get more. Day three, you're going to get more. Day four, you're going to get more. Day five, you're going to get more. This is going to continue to accumulate the more and more you take it. So the outcome ultimately is, what are the side effects? And there's lots of them. Skin changes are the most common. About 10% of patients who take this chronically get the skin changes, a rash, hyperpigmentation, rarely Stevens-Johnson's. And the neurologic side effects are also very common. You can see them all up there. I'm not going to read them all, but agitation, anxiety, mental status changes. For those of you who happen to prescribe Plaquenil for rheumatoid arthritis or lupus, you know all about the potential eye retinopathy. Patients need to go routinely to the ophthalmologist to make sure that they're not developing the retinopathy associated with this drug. The other one that I'm most concerned about is the cardiovascular side effects, because cardiovascular side effects can lead to sudden death. And I have up here, and I've highlighted the prolonged QTc, which is very worrisome, because that can lead to torsades. So who's at risk for getting the prolonged QTc and potentially torsades? Well, there is a congenital syndrome of patients who have long QT. You just have to be aware of that. Patients who have hypokalemia, hypomag, they're at risk. Women are more at risk than men. And then when you start combining it with other drugs that prolong your QT, then you have problems. And so what are those other drugs? Well, it seems like all of them. It just seems there's an amazing amount of drugs that can prolong your QT. I've got them listed up there. I'll just mention some of the common ones. The ondansetron at lower doses that we typically use, 4 milligrams, is very small incremental increase in your QT. When you start using larger doses, such as some chemotherapy patients get, such as 32 milligrams for their chemotherapy and induced nausea and vomiting. At that higher dose, then you get much more concern for QTc. So our cardiology colleagues have said, listen, we've back in 2013 developed this risk score, and we encourage you to use it. That is, they did a very large study involving some 12,000 patients. There was 9,000 in the derivation set, 3,000 in the validation set, that said, look, we're going to give you these points. And, if you don't have a lot of points, you have low risk for going on to torsades. If you got a lot of points, watch out. Please watch out and withdraw your drugs that could be prolonging QTc. And you notice right off the bat, just one drug can give you 3 points right off the bat. All right, that's hydroxychloroquine. Add a second drug, you get another 3 points. And well, we're commonly putting this together with this drug, azithromycin. So now you're already up to 6 points. And there's been, of course, reports about azithromycin just throwing people, young, healthy people, right into torsades. Now, these are isolated case reports. I understand that. When you look at the literature, does azithromycin increase your chance of sudden death? In an honest moment, I looked through the literature, and it's kind of a yes, no. Some say yes, some say no. So I can't absolutely trash the drug on this point. But be aware, it can prolong the QTc, and adding that to hydroxychloroquine can run into real problems. So why do we even add azithromycin with hydroxychloroquine? It's been a common combination. There's no clinical data, not one shred of a study that says in vivo that it will help. A lot of ideas, again, theoretically, that it, from some of the pulmonary literature, that it will decrease the pro-inflammatory cytokine production. So it might help us in that cytokine storm. It may have antiviral effects. It apparently does decrease some rhinovirus replication in vitro, and again, may inhibit some mucus secretion. So that's the theory why it got thrown into the mix here. But when you look back, at least when we look back at MERS, which is another coronavirus, when they look back at retrospective studies, so take it for what it's worth, 349 patients who got macrolide therapy, most often azithromycin, it did not improve outcomes. So on its own, it doesn't seem to improve outcomes. I'm going to blow through that slide. We do know that in reports from 2 reports where they combine their results of some 95 patients, about 10% of patients will get prolonged QTc and arrhythmias. I know at least on one of the patients that got sent up here from New York City, she was on both drugs. She was admitted by our hospitalist service. They fortunately recognized that upon arrival, her first EKG here, she had prolonged QTc, and they stopped both of these drugs at that time. So kudos to our hospitalist group for picking that up on one of those transfers. The cardiologists have weighed in on this and said, listen, if you're going to use this drug, A, you need EKG monitoring, and you follow the QTc. You have to correct the hypokalemia, you have to correct the hypomagnesemia, and you have to avoid all those other drugs that can also make things worse. From the emergency department standpoint, I'll just leave you with these in my last 1 to 2 minutes, is that we get very, very, very concerned about this drug. This is a little bit of an older study from 2001 that talked about acute overdoses associated with hydroxychloroquine. And as you see back then, it is very, very toxic. And what is concerning, you see one child died of it. And since that time, in 2008, another report came out on these 38 children that got called into just one poison control center regarding overdoses or potential intoxication with hydroxychloroquine. And we have to recognize that this is a drug has a very, very narrow therapeutic index. Its toxic dose is 10 milligrams per kilogram. So you take a toddler, take a 2-year-old who's under 20 kilograms. This is one of those drugs that can kill a toddler with one tablet. So we are very, very concerned in the emergency medicine world when we about this drug, about the potential for overdose and lethality. In adults, you can take 20 or 25 tablets and you'll kill yourself in an overdose. Why do you die of this drug? It actually has tricyclic antidepressant effects. So for those of you who remember tricyclic overdoses, these are problematic. It causes emesis, it causes CNS, seizures, hypotension because of negative inotropic effects, bradycardia, prolonged QTC, and hypokalemia. So how do we treat those? If you're in my shoes, early intubation, charcoal. From an early prospective study back in 1988, high-dose Valium was used. If you want to use another benzo, I think that'd be fine. Epinephrine you're going to have to go to. Just like a tricyclic overdose, you have to use bicarb, and lots of bicarb, and you have to correct the hypokalemia. So I wanted to get through that. It is exactly 9 o'clock. I got there right on time. But I do want to leave just 2 or 3 minutes for Dr. Finch to weigh in if you'd like on hydroxychloroquine.
Okay, I'm going to unmute Dr. Finch right now. And if anybody has questions, feel free to type them into the chat box. And Dr. Finch, you're unmuted.
Okay. I totally agree with you. Unfortunately, hydroxychloroquine, we're all on that bandwagon where everyone's doing it. The president is saying that we need to do it, and it's the old logical fallacy, what's the harm? Well, I think you were excellent in pointing out that there is potential harm. Here at Ellis Hospital, it's been tasked with me to be the one to approve it, and my own, being inside of this, my own threshold for approval of this is has been raised. I'm certainly not comfortable giving it to people with prolonged QT, people with admitted with a syndrome that I think that they're likely to recover on their own without treatment. And I have a feeling it's going to go away. It'll certainly go away when we find something effective. Back in the day, various non-actual antiviral things were proposed for HIV. That never panned out. It's just due to the crisis that we have, and during the Ebola crisis, there were failures. They waited for randomized controlled trials and none of those really got off the ground before they could treat anybody. So we're kind of stuck in a very bad position. I think Dr. Fauci is right when he says every time there's no proven treatment for coronavirus. Fortunately, our president is the master of using logical fallacies, and so are politicians. They use that slippery slope, or, what's the harm, or, if we don't open, we're going to ruin Easter, things like that.
Right.
He's just a master of all that, and it's put us in a very tough position. What we need to, what we're focusing on is how to ventilate these patients, how to take care of them when they're critically ill. I think that's the best thing that we can do for the patients right now, and allocate our resources like we have. Listen to Fauci is what I say.
So, Doug, can I ask a question? Because I see a number of primary care doctors on the.
Yeah.
So our primary care colleagues, if they have a patient who's an outpatient with COVID-19, and they get a call from their patient, they call up their primary care doctor. Doctor, should I take this hydroxychloroquine at home? Will you prescribe this for me, please? What do you think the primary care physician's response should be?
I say no, absolutely not. When there's actually the governor had one of his proclamations or whatever that it should only, or there was something that came down when we first started doing this, that it should only be prescribed by pharmacists for a clinical trial. Part of that was probably try to ration the drug, but I can't remember exactly, but I think maybe it's an exemption now for inpatients. You may not even be allowed to prescribe it. So it's a very, very, very tough position. And I think it's a very tough decision to give it to somebody who's well enough to be home.
Thank you. I do think there were some questions online. Emily, do you want to read those out, or?
Yeah, I'm going to read the questions out. I've unmuted Dr. Weinberg and Dr. Jones as well so that they can answer. Michael O'Brien asks, out of the vented patients at Ellis, what is the percentage of patients that are coming off the vent and improving?
I can't answer that. I'm not caring for these patients. I think the person to answer that, if someone's online, would be either Dr. Platt or Dr. McDonald. But unfortunately, I can't answer that question.
Yeah, I don't know if any of our intensivists are on the line. I don't have the answer either.
Yeah, I don't think they are.
Can you unmute me?
You're unmuted.
It's Dr. Finch. I think it's in line with what we've been seeing. 80–90% are still on the vent. If they get on the vent, either they expire or they're getting a trach and they're staying on the vent. It's been very difficult to wean the patients off the vent. They've been staying on for an extended period of time. I have a colleague who's an ID doctor at Elmhurst Hospital. They have 100 patients on ventilators. They have 400 patients in that hospital with coronavirus. And she says basically they're not, same thing. They can't get people off the ventilators. So it's whatever is causing the problem. I don't think we know why we do not know why some people get on the ventilator and some do not. That's really an important thing for us to figure out. What are the factors that get people on the ventilator? It's more than just the virus. It could be the cytokine storm. That has to be investigated. Everyone thinks it's something that we need to treat, but we don't know if treating that is helpful either. So once people are on a vent, it's a very difficult situation, especially if you're older. I'd say the mortality if you're in that older group, which is 60 and above, is 50% at least. Probably more like 80%.
Just to add a little comment, I'm not sure if we do it here, but proning seems to be very beneficial as far as improving oxygenation. And I will echo that Dr. Finch's comments that these people do stay on ventilator for prolonged periods of time. This was well established in the beginning, especially with Dr. Dong's experience at the Montefiore system. But yeah, that is a problem. But proning seems to help in that regard. And there have been a lot of failures when people have been extubated using conventional criteria. But again, I can't comment on the data.
Peter, we have been proning them here with ARDS, yes.
Good.
Okay, great. The next question is from Martin Farber. He says, nice overview, guys. Thanks. Remdesivir has significant proofreading activity along with its polymerase activity. Do you know if there are trials using a nucleoside analog along with remdesivir?
I don't, again, Doug, you're more up on this than I.
I think that might be a referral to ribavirin. If you go on clinicaltrials.gov, there are trials looking at that. It was used as an adjunct for hepatitis C treatment when we were using interferon, and combined it with ribavirin, it did improve the viral efficacy, but ribavirin has its own toxicities, and it's not something I would add on. I have a lot of experience with ribavirin. I would not do that outside of a clinical trial.
Mm-hmm. Bob, can I ask a question?
Sure.
Right, just looking at your comments on hydroxychloroquine, and just a couple of questions and points. Is there a difference as far as toxicity goes between self-limited acute intervention versus chronic? And also, by analogy, we, for a while, were prescribing azithromycin to our chronic lovers who had recurrent exacerbations. It was found to decrease that. And we had people on trials for years, and while QT prolongation did occur, the incidence of torsades in negative patients did not. And so, granted, when you have a second drug, I mean, the incidence certainly goes up. But if you have somebody on it, is there any role of beneficial supplemental magnesium? Because we use that to treat torsades, and certainly would it be of benefit in preventing a prolonged QT from deteriorating or into torsades? Or as the Italians say, torsione de punta.
So you gave me two questions. The first one being the acute versus chronic
Use of hydroxychloroquine.
associated with hydroxychloroquine. So obviously, the chronic ones, the chronic problems are with accumulation over the years in particular, as I've already said, is the retinopathy you're really, really concerned about. Obviously, in this acute setting, that it's too short a time to even tell if there's any sort of retinopathy that's developed, and so I can't comment on that.
I'm going to.
What we've seen is clearly, as I told you, 10% of patients, at least 10% get the QTC and have to be removed, or some arrhythmias. Talking with Dr. Jay Kahn, we've had some arrhythmias here.
Okay.
And the other thing that's been shown is that there's been a couple trials now of high-dose hydroxychloroquine, and they get about 30% of those patients will get diarrhea. This is when they start using 1,200 milligrams of hydroxychloroquine. There's one trial out there. So those are the two acute ones that you have to sort of be aware of.
The second part of the question was.
Just empirically adding magnesium, I can't do that. Yeah, go ahead.
That was the question, yeah.
Yeah, this is
Okay.
Doug. Can you hear me?
Yep.
So the dose of hydroxychloroquine that we're using is on the lower side.
Right.
It's 400 BID the first 2 days, and then 200 BID for the next 4 days. So that's lower than the usual dose of Plaquenil, which I think is like 600 a day. FYI.
Okay, great. I'm going to move on to the next question. It's from Dr. Dean Lemire. He asks, will we be at a place where we will use some of these therapies earlier in the disease where they might have an effect if used earlier rather than later?
Well, you need data for that, but I think that's where I would go. I agree with that concept.
Yeah, there are randomized controlled trials of Remdesivir ongoing for prophylaxis and exposures, pre-prevention, but currently it's an infusion. So that's obviously not practical, but hopefully there'll be an oral formula. If it's effective, then they'll go to an oral formulation.
And then you speak about using it early. There, I understand there's a trial. Again, this is all trials. Emergency medicine workers who quote are exposed. Just put is a trial doing prophylaxis versus no prophylaxis. I don't know if I'd sign up for that one myself, but there is that ongoing. But right now, there's I can't point to any data, at least hydroxychloroquine, to use early.
Okay, Dr. Yap has a comment. It says, China trial number 1 has been quoted by Peter Navarro as being why he wants to get a second opinion against Dr. Fauci. I read that paper, and to me, the study was stacked against the control. The control is sicker than the hydrochloroquine. You can read it at medrxiv.com.
Yeah, the medrxiv.com is where they're actually putting all these pre-printed, peer-reviewed articles for you to sort of get your hands on. I don't know if that's good or bad, actually, because it may lead to people like Peter Navarro getting their hands on it. But you know, and they're not rigorously, they're not even yet peer reviewed. So you have to take all those studies in that area and just take a really scientific, skeptical, critical eye to them.
Okay. Martin Farber says, this is a bit off topic, but I have heard that intubated patients may respond better to treatment for HAPE rather than ARDS. Anyone have any thoughts about that?
I'll skip.
Yeah. HHP is what?
But yeah, not what.
You already answered mine then? No.
No.
I'm not sure. I'm looking to see if he answers it below. HAPE context is high altitude pulmonary edema is what HAPE is.
Right. Yeah.
Okay,
There's been enough. There are actually a couple of phenotypes of respiratory failure, and one is a happy hypoxemic, which is one type, and these patients have can line up on mechanical ventilators, but they have very good pulmonary compliance versus the standard ARDS patients. So you have to be careful, and one of the things that people are recommending is that use driving pressures for this. So again, you have to break down the phenotype. I know there have been comments about the analogies to HAPE, et cetera, but again, work in progress.
Yeah, I agree. I mean, these are all things that should go into clinical trials. I mean, other things I've heard bandied about: nitric oxide, hyperbaric oxygen. You know, those are things that are hypotheses for a study. And because of the urgency of the crisis, people want to just start doing it.
Yeah, and I agree with you, Peter. You know, there's the two types, and I think they're calling them subtypes L and H now. L meaning that you have still good lung compliance, and the H, the latter stages, is the ARDS, where you got very poor lung compliance. And I think that's what they're calling these subtypes now.
Well, yeah, that's actually the work of Gattinoni, who proposed it. He did about the L and the H.
Right.
L was low elastance, H is high elastance. High elastance means low compliance and vice versa. So
what we're trying to do in the at least what we're hearing in the ER settings is that if you have, if you're in the L, try to avoid the intubation at that point and just go with high flow oxygen. But this is all going to sort itself out.
Dr. Rob McHugh has stuck a link to a YouTube video about high altitude physician talk in the comments if anybody wants to take a look at that. I'm going to go on to the next question. Dr. Galat says, with tongue-in-cheek, pediatricians have been telling me for years that kids are not small adults. Is this no longer true? And we apply adverse kid data to adult studies, I'm assuming?
I don't know if Dr. Glatt's pointing out my discussion of peds. And so, Dr. Glatt, I'm not sure how to respond to that. But all I can do is I'm just giving out the pharmacologic knowledge that I've been given, and people have told me that this is what is written as the toxic dose. I can't comment much more.
Okay, and then we have another comment that says the executive order in New York State is that you cannot order hydroxychloroquine. Not sure about that. Okay. Dr. John Assini asks, I believe that the dosage of hydroxychloroquine is usually higher than the dose we use in SLE or RA. Do we know why? These adverse side effects are not prominent at the doses we use in rheumatology.
I cannot comment why they started choosing the dosing they did. I'm going to pass.
I think it's just from some in vitro studies of what would be the most effective, or whatever, the least toxic, most effective antiviral dose, you know, one of those, I don't know, MIC type things.
Yeah. I do think that the fourth study I gave, I then put the dosing up there, as Dr. Finch noted, you know, the 400 milligrams BID initially. That came from that study, but again, that in vitro study. But we could be right, we could be wrong on the dosing. I have no idea.
Okay, and then I see a comment from Dr. Yap that says there's an essay by a Wuhan physician in sixthtone.com. She reports the need to ventilate earlier rather than wait till it's too late. She reports the earlier a patient is vented, the better they will recover. Any comments on that?
I have no experience. I can't. I have no data.
So that was the initial word we got in emergency medicine also. Then people started saying, well, if it is that L type where they have good compliance, back off and try to get them through with you know, high flow oxygen. So it's kind of a yes/no on that statement.
Just a word on a sidebar that there's been a lot of success in Europe using a helmet with positive pressure via CPAP or PSV, and also prone patients on helmets, and apparently doing that successfully. So we don't do this in the United States. That may be something also to look at, most patients.
We're going to need a lot more PPE if we do that.
Yeah.
Because of the aerosol.
Unfortunately, the helmets are available in Europe, but not in the United States. You know, and there are actually some companies now trying to manufacture that, but you know, we've lagged behind some of the medical innovations that have been implemented in Europe, not just in COVID-19, but in other aspects of medical care as well.
Okay, so I'm not seeing any more questions right now in the chat box. Dr. Jones, do you have anything you'd like to say?
Just thank you so much to our speakers today. This has been excellent, and there's no doubt all of us hoped that hydroxychloroquine was going to be this magic bullet, and we're just all hoping that we can find something, but we greatly appreciate how we need to be a little more cynical about this whole thing. But thank you again to our speakers, and again, we're planning to have a grand rounds where Dr. Peter Weinberg will be joining us again and sharing his review of the literature. Thank you all again for being with us.
Thank you. Have a nice day.